The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We're here again for another episode of TMD Demystified, and I am Tony Urbanek. Today, I'm going to step out and pick a topic that is kind of questionable as far as whether I should do this or not. But the title of the topic today is What's in the Future for TMD? Again, I think about the topic prior to jumping on the episodes, put a little effort into it, and I really debated whether this would be an appropriate topic to talk about what I think, my opinion is, what the future of TMD is all about. But I think I'm qualified to make some comments about this because of all the work I've done regarding TMD throughout my career, including 30 years of surgery, temporomandibular joint surgery, in the past 11 years of non-surgical TMD treatment, and the thousands of patients that I have encountered, both surgical and non-surgical, over that period of time. And the majority of the quantity of patients that I've seen has increased logarithmically over the past 11 years. So I think I'm qualified to talk about TMD. If for no other reason that I've talked to, examined, done consultations for, let's just say, the past 7 years for roughly 5,000 patients with TMD symptoms. I would question whether anybody in the country, any other provider in the country, and it's not a competition. I don't feel I'm in competition with anybody on any front for any reason, but I would guess that 5,000 people, consultations within 7 years for TMD services, that's probably at the top of the heap, I would guess. And if somebody wants to take issue with that, put it in the comments, which brings up the first thing I'd like to talk about before I get into what's in the future for TMD, my opinion, based on my experience and my work in the area. And that is that I'm not getting any comments. This is going to be the 72nd episode of TMD Demystified. And almost every time I finish up an episode, I encourage communication, I encourage comments, and on the platform, Dentaltown platform, which now has going to have 72 episodes, not one person has made any comments, positive or negative, or questions regarding anything that I've placed on the platform, which frankly surprises me. In fact, I guess I'm pleasantly surprised, because I was expecting, differences of opinion, or someone coming on and make comments that they think I'm out of my mind or I'm not on the right track. But I've encouraged anyone who listens and participates in this exercise to be critical. I mean, if you can find a better way, if you have better information, if you have better experience and can document it, I'm willing to listen, and I'm willing to debate, or I'm willing to comment, or I'm willing to get in communication with anyone. But based on the information that I have and what the information I've been exposed to, I stand by every word that I've commented in every episode that I've made on this platform. So again, I'm surprised that no one has commented about this. And I would expect, if anything, lots of comments about what we're going to talk about today for the next 20, 25 minutes, which is what's in the future for TMD. I think TMD has a very bright future as far as the solution. Obviously, I'm biased because there's this thing called the Urbanek device and protocol, which now has a university study which verifies our claims, and patented, FDA approved, et cetera, et cetera. But let's go through the portions of this that I wanted to take up, and that is, first of all, the providers for TMD services. You have to have some kind of dental training to provide this service. Medical doctors are not in a position to handle their own diagnosis. We've discussed significantly in prior episodes the fact that a huge number of patients have been diagnosed with migraine headaches that don't have migraine headaches. They have TMD headaches that are really, really bad. And it's a huge misdiagnosis group. And we're doing our part here in Middle Tennessee to fix that. And to a large degree, we're making great inroads, but we just see thousands of patients. We don't see the millions of patients who have this misdiagnosis. Physicians are not able to use a dental device and have the concept of dental impressions and understand the mechanisms of the temporomandibular joint and associated muscles and bone and function of the masticatory system. They're just not geared for it. They never will be geared for it. So this is primarily a dental function, and to get the solution out there, a lot of extra training has to be done, although it is not complicated. I make that really clear throughout the episodes. This is not a complicated problem, although there are a lot of providers out there who want to make this complicated. Had an example of that a patient brought to my attention yesterday. I won't go into it deeply, but it was a 3-hour examination, not by the doctor, but by an assistant. This came from the patient's mouth. And then the doctor came in and did about a 5-minute introduction in history, and then a recommendation was made for TMD treatment. That's a fact. It happened yesterday. On one level, I don't understand it at all. On another level, I do understand it because I am well aware of the alternative treatments that are out there for TMD. I won't phrase it any better way than that. We'll just call it alternative treatments. But that is what one patient told me about one doctor and one episode, and it just happened recently, and she's sitting in my office and ended up with a 20-minute consultation. She went on with treatment. The point being about this is this is a huge problem which needs to be solved. Our medical colleagues cannot solve Meniere's disease. I had a patient yesterday. Today is Tuesday, and currently I only see patients on Monday, so I'm well loaded with patients to talk about on a Tuesday morning. And had a patient yesterday who came in to see me, who had, all of the typical symptoms and had been around the bush, with, she said 15 doctors over a period of years. And half of them were medical doctors, and the misdiagnosis was made about Meniere's disease. And our medical colleagues and our ENT doctors diagnose Meniere's disease. They have a name for the problem, which is tinnitus, subjective hearing loss, and vertigo, called Meniere's disease, but they have no solution. And we know that thousands of people have this diagnosis, and there is no solution from the ENT doctors. But if those symptoms are coming from inflammation within the temporomandibular joint, and many of them are, huge numbers of them are, if you make the inflammation go away, the symptoms go away. So There's a huge opportunity, this is the point, it's the word, opportunity for my dental colleagues to grab a hold of this and bring the solution to the medical community for just those two symptoms. And then the third one, which is highly, highly misdiagnosed, is ear infections. Yesterday, I had another patient come in for a consultation, and she had been seen by, I believe, when she got the whole story out, 3 separate practitioners who said she had ear infections and was given antibiotic for ear infections. 3 separate practitioners finally ended up with an ENT doctor who has been schooled by us about the diagnosis of TMD. The ENT physician sent her to us, and sure enough, she had hot joints, and she had the symptom list, and she had TMD, which we got her in line up to get treatment. My point being, as I've talked about before, huge problem of misdiagnosis from our medical colleagues. And it stands to reason that at least some of you out there in the dental community needs to jump on board and take this opportunity, if nothing else, to fix it for our medical colleagues. And then, of course, how do you make the medical colleagues aware of this? Well, we work that out too, as far as how you market it to medical established practices, not just the public. I mean, you can market it to the public, but the real low-hanging fruit is our medical colleagues who misdiagnose it all the time. And we worked out that marketing program. It's extremely successful, to the point that here in Middle Tennessee, in this practice, we have in excess of 700, I don't know exact number, 750 to 800 now referral sources who send us TMD patients. The doctors want the answer. Once they understand, they want the answer. They're happy to refer the patients out to their dental colleague if they're sure and they know that there is a solution, and that the dentist, the dental colleague, dentist, oral surgeon, orthodontist can actually provide the correct service. Next point is, so I envision that not every dentist is going to be qualified or interested in doing TMD treatment. It is not complicated. And of course, we have the course that teaches you how to do it, and we're making it simpler all the time. So I envision that, within a few years, we'll have thousands out of the 150,000 dentists in the United States of America. I'm guessing we'll have 3,000 or 4,000 within 10 years, maybe 5 years, but thousands who understand the true mechanism of TMD, which is inflammation causing all the symptoms, nothing to do with myofascial and position of the disc and all this stuff. If you can get rid of the inflammation, you can get rid of the symptoms. So there'll be thousands, and it has the possibility, and I think high probability, that the interest from the practitioners, either driven by the practitioners or pulled from the practitioners by the patients who are finally aware that there is a solution, will bring as much activity as aligners, because this is a big problem. 46% of females have temporomandibular joint symptoms. Most of them have been misdiagnosed on one thing or another. So I made the point. That's my prediction. That is what I believe is the future for TMD. It is not a complicated problem once you understand it, which is all that information is. And by the way, all that information now is on prior episodes on this platform, Dental Town. One or more of the 72 episodes are available. Next point is education. My vision and my forecast is that the concept of TMD will be taught routinely, necessarily, in dental schools. Again, because it is not complicated. The emphasis, though, will need to be primarily on the basic sciences, not on a surgical aspect. We'll talk about that briefly in a minute. But the simplicity of understanding how inflammation creates all these symptoms, these eclectic symptoms within the body. And once that is understood, which is a concept which should be taught in the basic sciences before you get into the clinic. And so a little time, probably no more than a few hours of information disseminated about cell biology and the autonomic nervous system, and how the autonomic nervous system sends signals to tighten up the muscles once inflammation in the joint is present. We talked about in prior episodes the tennis elbow, which is nothing more than inflammation sending signals to the brain stem. The brain stem says tighten up, and the muscles that move the elbow tighten up. That needs to be taught in dental school in the basic sciences. Our orthopedic surgeons know all about this. That's where actually I came to the conclusion of how this works, because I was familiar with orthopedic surgery, and my orthopedic colleagues in my training at Vanderbilt taught me about tennis elbow and how the autonomic nervous system sends out a signal to tighten up when the joint becomes inflamed. So I look to the education dental school regarding TMD to change drastically, but not greatly. It isn't a matter of spending a lot of time. And once you understand that, then unloading the temporomandibular joint by unloading the posterior teeth will decrease inflammation adequately to relieve all these symptoms. And then once it gets into the dental school, then you will have many, many young dentists acknowledging and using this simple technology to treat patients in their practice. And again, it's all about the patients. If you have 45% of females, that's running the arithmetic, 76 million females in the United States of America, and just females alone, not counting the thousands, actually millions of males who primarily in their symptom list complain of the Meniere's symptoms, ringing, fullness, and dizziness. The males come in primarily with those symptoms, although there are many painful males. So our educational system is going to change drastically, but not greatly, but drastically in the emphasis on treating TMD once the simplicity of the problem is understood, rather than what's going on now. And a good example of that was the patient exchange that happened yesterday, telling me exactly what happened going to a local practitioner here actually in Nashville. Additional training will go on beyond what dental school has to offer, primarily for people who didn't pick it up in dental school. And again, whether the training is online training or in-person training, I think because of access to the internet, I think pretty much everything will be online. It is not complicated in how it integrates into a practice extremely well. The time necessary to treat a TMD patient is not great. I mean, for example, what I use as an example of this provider that's patient spent better than 3 hours in the consultation. In our practice, start to finish, consultation, delivery of the device, and appropriate follow-ups over the next 4 to 6 months will take maximum of an hour. That includes the consultation. And in my experience, because I do so much of it, I mean, basically I'll invest 45 minutes, 20 minutes or so for a consultation, and the rest of it is delivery and follow-up and check patients, make sure they're doing well, to the point where they can be discharged with them stating to me, that 85 to at least 85% of their original complaints and symptoms are now diminished or gone. Most of them, almost all of them, are in the 90% by the time I feel comfortable and say PRN, return is needed. So it's not a time-consuming thing, but additional training on the issues are easy and will likely be all online. which we do have online now as our online course, but that's what I see in the future. And then the integration with other services. And that is a little more difficult to explain or talk about, because what I have observed and what I found treating, well, in excess, now we're approaching 4,000 patients here in the past 7 years that we have treated and successfully. And what we found is that the other services in dentistry have an integral part to play in this, beyond just diagnosing it, treating the symptoms, decreasing the inflammation, because what you would treat beyond the symptoms are the causes, and the three primary causes of inflammation within the temporomandibular joint are: number one, bruxism; number two, acute trauma; and number three, functional malocclusion. And the other services, which I'll define for you as orthodontics, general dentistry, and oral and maxillofacial surgery, have, and we'll include pediatric dentistry, I guess, have a large part to play in treating these causes once they are identified when you run into a patient with TMD. And of course, let me go through this briefly again. It's in other episodes, but there is no solution for bruxism. Don't let somebody smooze you and explain that they have a solution for bruxism. There isn't. We don't understand the mechanism inside the brainstem. We know that stress causes excitation of the brainstem, which creates bruxism. That's pretty much all you can say about it, but exactly how that goes anatomically and physiologically, we're only guessing. And we definitely know that patients have no control of their bruxism, although you can decrease stress for sure, but that's a very individual thing and a very fluffy kind of thing, and not necessary at all. You do not have to treat the patient's anxiety to treat their bruxism to make the inflammation go away. You can make the inflammation go away and let them brux as much as they want. So, bruxism comes out of the equation, but if you have a functional malocclusion, the orthodontist comes into play is to treat the functional malocclusion once it's identified. If there's a functional malocclusion, the general dentist on some cases will need to consider occlusal reconstruction, but not all cases, and it's not that common, but it does come up, and sometimes in conjunction with orthodontics. Again, functional malocclusion sometimes needs to be corrected with a combination of orthodontics and orthognathic surgery, which brings the oral and maxillofacial surgeon into the midst of it, which is necessary. And then the pediatric dentist, who sees increasingly older patients in 15, 16 years old, is going to have an increased number of patients that they see with sleep apnea, because both in my experience and my colleagues' experience, especially my colleagues who already commented in their practice, the great numbers of 15, 16-year-old, 14, 15, 16-year-old females who in their office complaining of significant pain coming from the symptoms associated with TMD. So the pediatric dentist is going to be much more involved in diagnosing and likely treating TMD, although you cannot use a device in mixed dentition. Don't go back that early. But the 15, 16-year-old females is a very common group of individuals who come into the office. So all of these associated treatments which treat the causes of inflammation will come into view better, and then we'll give the opportunity for these practitioners, the pediatric dentist, the orthodontist, the oral maxillofacial surgeon, the general dentist, to get involved and to do more services that the patient needs, that the patient actually needs to handle the causes of inflammation, the damage to the temporomandibular joint, the causes of inflammation. And then a comment about doctors who do sleep apnea and obstructive sleep apnea, sleep dentistry and obstructive sleep apnea treatment using devices. This was discussed in a prior episode, but the fact that an OSA intraoral device literally pulls the mandible forward and the condyle out of the fossa creates damage within the joint, whereas unloading the joint, allowing the temporomandibular joint and condyle to go back into centric relation is actually what smooths out and decreases the inflammation. So doctors who actually treat obstructive sleep apnea with intraoral devices will need to be well acclimated and schooled on the difference between the device that pulls the mandible forward and the device that allows the mandible to go back in a comfortable position, centric relation, decrease inflammation within the temporomandibular joint. That is in the future for the treatment of TMD. And it's all about knowledge. It's all about awareness. It's all about understanding the simplicity of it, which once understood, then we'll bring out large numbers of practitioners who are not afraid of treating temporomandibular joint patients. You know, the statistics are now very obvious. They've been there since I've been in practice. Half the dentists don't want anything to do with TMD because they think it's too complicated and the patients are extremely difficult to deal with. They don't want anything to do with it and that there is no solution. And the other 50% make a night guard, give it to the patient, which has got to stop. It's just got to stop and tell them that's their TMD treatment. And that brings me into the excluded, rejected, and found invalid and unnecessary treatments. The future, again, getting back to the topic, what's the future of TMD? The future is, just like I discussed, just like I said, the night guard for the treatment of TMD it's going to be a thing of the past. It's pretty close. The word's going to get out, and once it gets out, and especially gets into the dental school, then it's over with for the night guard treating TMD. Surgery, the things are going to be excluded, rejected, and found invalid. There's going to be very, very few necessary cases to do temporomandibular joint surgery of any kind, whether it be starting with lysis and lavage all the way up to total joint reconstruction. I think that there will be some types of temporomandibular joint surgery which will be necessary. Number one, the future will be bright for patients who are edentulous and have temporomandibular joint symptoms. I can talk about that extensively and what I would recommend for an edentulous patient as far as surgery goes. I won't bring it up now, but they are not in the majority by any means, but there are great numbers of patients who are edentulous who have temporomandibular joint symptoms directly from inflammation within the joint. And for those patients, surgery is probably, I believe, your best option. And then patients who have such great destruction, and I'm not talking about just dislocation of the meniscus or even osteoarthritis of the condylar head or subcondylar cysts. I'm not talking about those patients. Those patients are easily treated. The symptoms are easily treated when you unload the joint and the inflammation goes away. But there are cases where occasionally a total joint will be necessary, sometimes in association with orthognathic surgery, and of course, in certain kinds of trauma. But most of the surgery will be a thing of the past as it treats temporomandibular joint problems. MRIs and CT scans for the temporomandibular joint problem are unnecessary. It is a huge number of dollars that are being wasted currently on MRIs and CT scans. I wish the insurance companies would recognize that. Sooner or later they will, although I'm not sure insurance companies are actually interested in saving anybody any money. And I say that, I stick by it. Anybody want to make a comment on that? The MRIs and CT scans aren't necessary. A good Panorex, just to make sure you're not missing something, that there's something there that is obvious, that, you know, a sinus that's full of stuff or a tumor in the sinus or whatever, it can be easily recognized on a Panorex, and whatever the cost of a Panorex is about 5% of what an MRI or a CT scan, including cone beam CT, is going to cost. So I think for the treatment of TMD, MRI and CT scans are overkill. Obviously, drugs for these symptoms are going to be a thing of the past. That's not going to make pharmaceuticals very happy, but that is my prediction. That's in the future for treatment of TMD. Drugs will not be used for the majority of patients who have bad headaches, quote, migraines. Muscle relaxants won't be necessary. Unnecessary. All these drugs are unnecessary. Of course, people who try to treat it with narcotics and things, and probably the number of antibiotic prescriptions is going to go significantly down because the number of practitioners who misdiagnose these ear pains as ear infections rather than true inflammation within the joint will go down. So, pharmaceuticals are going to take a lick on antibiotics. All forms of diagnostic machines for the treatment of temporomandibular joint. I've seen all kind of patients hooked up to all kind of machines for the treatment of temporomandibular joint. It's over with for those. It's not going to happen, including the stethoscope. Who cares what the joint sounds like? And you can't diagnose a temporomandibular. A stethoscope has no factor in diagnosing TMD. If a joint makes noise, it makes noise. And a damaged joint's always going to make some kind of noise. So why do you have to specify what kind of noise? It's like, I guess that's what part of the 3-hour workup was. It was about the patient told me about, is what, defining what kind of noises were coming from the joint. That's all a thing of the past, not going to happen. And finally, any kind of psychological treatment to the patient, although patients certainly have baggage that they bring into a practice. And if you're a practitioner of any kind, you know that. But the objective is not to unload the patient's stress. The patient can do that. They want to do that independently, but treating TMD by psychologists and trying to unload their stress is not a valid, successful treatment, because everyone has stress, and it's a very personal thing. But you can't stop anybody from clenching and grinding. It's not going to happen. So that aspect of treating TMD is a thing of the past. So with that said, I've spoken my piece. That is what I believe is the future for TMD. Whether it takes 5 years to get there or 10 years to get there, we are on our way. And our company and our purpose is to provide a logical, workable, scientifically proven system which unloads the temporomandibular joint adequately to the point where the inflammation decreases and all the symptoms go away. That's called the Urbanek device and protocol. If you'd like to become a network provider, you can contact us at our company. Company website is www.tmjservices.net. I am available for comments, criticisms, and discussions and communication at Tony@tmjservices.net. Our Director of Marketing and Education, Naomi, can be reached at Naomi@tmjservices.net. So for today, I appreciate your attention. I would encourage comments. How do you look at TMD in the future? And what part would you want to play in it? I'd like to hear. This open for comments. Until next time, until next Tuesday morning, which will be published on a Thursday, this is TMD Demystified, and I am Tony Urbanek, and I look forward to speaking with you and seeing you again in a week. Have a good one.